for your sister. It was beautiful. Thank you. One more round of applause for Dr. J. So welcome back, everybody. I think we had a wonderful day yesterday, and we want to switch it up today and sit next to someone new. So up, 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 find a new friend. Everyone's up. Get introduced to someone else. Everyone's staying. They found their friends. No one's moving.
I'll move.
Okay, we tried, Joe. And Suzanne. Okay, a brief review of the agenda for this morning. You're going to hear from Dr. Robert Maki, Bob Maki on clinical trials, Dr. Bob Benjamin on chemotherapy. And then after the break, we're going to hear from Dr. Venkat on radiology, Dr. Joel on surgery, and then Dr. Giacelli on radiation therapy. And then after lunch, we're going to hear some more about how to deal with the side effects of cancer and treatment. Dr. Soares will be here to speak about palliative care. Dr. D'Amato is going to be here to speak to you a little bit more about nutrition. And then Anna Mae Elise is from University of Miami, and she's going to speak to us about physical therapy, exercise, and fatigue. And then, of course, we couldn't be having this wonderful conference this weekend without our fabulous sponsors, Lilly, ASI, Epizyme, Novartis, Genentech, and Daiichi Sankyo. And especially thanks to everybody who has participated, exchanged information, made new friends, and really made this conference a fabulous event for everybody. So with that, our next speaker is Dr. Maki. Dr. Robert Maki is a professor of medicine from the Northwell School of Medicine. Professor Cold Spring Harbor Laboratory Director, Center for New Cancer Therapies at Northwell Health Institute. Dr. Maki earned his MD from Cornell University Medical College and his PhD from Cornell Graduate School of Medical Sciences in Immunology and Molecular Biology. He completed his residency in internal medicine, Brigham and Women's Hospital at Harvard Medical School, and his fellowship in medical oncology at Dana-Farber Cancer Institute. I used to work there at Dana-Farber. Okay, great. So welcome, Dr. Maki.
Thanks very much, everybody. And, that's hard to follow that, but try and make us change directions a little bit. What I'll talk about today really will apply across the next several talks. Research can happen in many realms, as hopefully you'll learn from this slide presentation. And you'll see that there's really been a lot of thought that goes into trying to make sure that people are safe as they go on trials. And this has a lot to do with, it's really been, unfortunately, something bad has to happen before a change is made, and that's happened many times. That's really led to at least some of the foundational documents that we use as our touchstones for conducting clinical research. It continues to evolve. These are documents that we continue to follow and continue to use in new iterations, new versions of them, to try and take more detail into account regarding how to properly conduct research. So this is a picture of the labs where we have the occasion to work one day a week at least, and those are always the fun days. It's a great place to visit if you have a chance here on Long Island. For some reason, they offer tours on the weekends to see where so they have something like five Nobel Prize winners who've been on campus there over the years. Conflicts of interest is an obligated to show. All right, so what is clinical research? That's going to be the question and answer format. You'll see just some slides, introduction, and some of the reasons why we have patient protections in place for clinical trials and what they exactly are, and then just a few examples of what might qualify as a clinical trial. research. And then lastly, just a few slides on how to use clinicaltrials.gov, the website that might be relevant for you or a family member. It's just good to see those, just at least some screenshots of exactly how that works and hopefully can be passed along as well. So let's start out just with some very introductory ideas here. What is clinical research? We talk about it all the time, but what is it exactly? Everybody who, you know when you see it, I guess, but I define it at least as the gathering and analysis of existing or new information to help answer a medical question. So this can take many different forms. What is a clinical trial? We always think about treatment studies as the most common sort of clinical trial, looking for new medicines, for example, that might help somebody, or new treatment modality that might help somebody. Clinical trial is a tool or a structure to obtain information that helps answer one of those medical questions. It's basically the rules of the road, the guidebook, the recipe that you have to follow in order to conduct that research. And as you've written this document, it gets reviewed and vetted by different committees within the institution you work, who confirm or refute that it's a reasonable way to move forward with that research based on some of the documentation that we'll see later. And the question that you look at should give a health-related biomedical or behavioral outcome or outcomes. You're allowed to ask more than one question, even though each clinical trial really should be principally asking one question is the most important, and that gets stratified as you write out these documents. Are clinical trials the only kind of clinical research? At least treatment clinical trials? No, of course not. You can examine patient data, go back to your database of everybody with a particular diagnosis and see how they did, or what are the demographics, how many are men, how many are women. There are not many men with uterine sarcomas, for example. Or you can collect information from questionnaires or interviews. That can also be a type of clinical research. What did you feel? What did you experience as part of your treatment? Those questionnaires, patient-reported outcomes are increasingly important. It's a whole different talk. Hopefully, it'll be a good talk for a different symposium, Gina, perhaps. And clinical trials don't always involve taking medicines, to be sure. You can take many forms. As I mentioned already, you can have questionnaires or fill out spreadsheet. Have an iPad with documentation of how bad is your pain right now, how much nausea do you have, if you want symptom scores, for example, you can collect those very easily, because certainly from somebody asking you that question, physician, nurse, PA, what have you, there's the loss of information from you actually documenting it yourself to the old kind of the telephone game where you're passing that information along to someone else. There's always loss of fidelity that way. For example, so questionnaires can be very helpful in helping us understand better what people are actually going through. And then another type of trial, you can use a different type of blood test or urine test or new scan, or a test of a tissue sample to find out if your diagnosis can be predicted better, or can at least link the diagnosis or whatever you're testing to a particular type of treatment. So this can be a different type of clinical research as well, but it still requires that we have the information about all the people who are on the study, so we can make a link between the new test information and what happened to a person. That correlation, as it's called, will help you hopefully learn something more about that particular diagnosis. So do I have to take part in this study if I'm offered? Is it mandatory if you do so? Of course not. Taking part is always voluntary, and we'll get into some of that, the reasons for that in just a moment. And also, if you start a trial, it's like I don't like taking part. It's too much taking too much of my time to be involved, or I'm having too many side effects from this. It just isn't for me. We're just not managing the side effects well, and it's just too much. You're allowed to change your mind. You can withdraw your consent for participation, taking part in a clinical trial anytime you wish, and that's important. You shouldn't feel badly, and that is all written out there in the consent forms that you end up signing for taking part in clinical trials, but I'm not sure that it's emphasized enough that you are allowed to stop anytime you wish, even after the study's done. If they're, for example, still collecting data, you can say this, I don't want to be bothered by these phone calls anymore. Thanks very much for allowing me to take part. That's all okay. So, but what if you do decide to take part in the clinical trial? What is your role in all of that? The key idea here is, just as the investigators have to follow the playbook, the rule book, so should you. You should follow the directions of the study to the best of your ability. Obviously there are things that get in the way. Let's say there's bad weather and you can't make it in for a clinic visit you're supposed to have. Just like with regular treatment, it's not a big deal. That's something to work around. But you do the best you can in taking part in these trials. And it should be all laid out to you in terms of how frequent visits might be, what kind of information is being collected, how much time is it going to take, that sort of thing. All that should be laid out to you in the description of taking part in a trial. The big question is, I'm going to be a guinea pig. Is this experimental medicine? Am I going to get a placebo, or is it really safe if I'm going to take part in one of these trials? And this is really where the rubber hits the road. Let's start talking about some of these documents that we follow as most important for actually conducting clinical research. No, of course not. You won't be a guinea pig. And in fact, there is always some risk in taking part of a clinical trial, even if it's a later stage study of a drug that's already approved. Let's say you're studying an old drug and a new diagnosis. There's still possible interactions there that haven't been seen before, or perhaps you would end up with a rare side effect if you're being treated with a new medicine that's only seen in 1 in 1,000 people. If they haven't treated that many people, you might be the first person to have that bad side effect. So there's always some risk in taking part in trials, at least of new medications, and at least theoretically from your test. But the study has been carefully reviewed to make sure that the new treatment or test is as safe as possible. And this is where institutional review boards, IRBs, they do have patients and patient advocates on those committees to help ensure patient safety. All right, so we'll talk about these protections that hold for people in clinical trials. This research is not done willy-nilly. That's for sure. They say, well, we're going to try this new treatment, and let's try this for you. Yeah, how does that sound? Well, there's a lot of background that goes into it. You're not just allowed to pull, at least the principal, pull stuff off the shelf and give it to people in an unstructured manner. And this goes all the way back, obviously, to again, learning from the terrible things that have happened over the years. Mengel's experiments at Auschwitz. It didn't matter if you're Jewish or twin or a child, or was people with other abnormalities, and oftentimes killed at the end of experiments. This, of course, led to the Nuremberg trials and the Nuremberg Code. And really, it pointed out that other than the Hippocratic Oath, there really wasn't a document for principles on actually conducting human research before this time. And the argument actually was used by Nazi doctors during their trial that there were no laws against this. And it led to these key principles of the so-called Nuremberg Code. And interestingly, the document that was let out, the atrocities that took place from the Nazis wouldn't be illegal for those guidelines, amazingly. It was imperfect, but it was the precursor to other documents and ethics that were later written. And of course, closer to home, here in the US, we had our own, even after World War II, it's amazing that this went on until 1972, in fact. The Tuskegee Airmen study, where men mostly were essentially given syphilis and then were not treated. They were just observed for what would happen. And amazingly, about 20% of them or so were still alive in the 70s, and about a third or 40% had died of syphilis or its complications over the course of that study. As you remember, the people who took part in that study were offered free medical care and food and free burial insurance in exchange for seeing what happened. And it was supposed to be a 6-month study, but it ended up going on for 40 years, unbelievably. And there was, penicillin was a standard of care as of 1947. Everybody should have been treated at that point. It's just amazing that this happened in a relatively recent era. And similarly, research supported by well-known groups in the United States, again, were treated with active sexually transmitted disease, bacteria, syphilis, bacteria, gonorrhea, chancroid, or forced to have sex with infected prostitutes, and initially no treatment was given, and many of these people ended up dying of sexually transmitted disease. And the work was done outside of the U.S. because it would likely raise attention within the United States. So what rules in one place may not be the same as another. This is why we need a universal code, no matter where you are, to ensure that people are treated appropriately, obviously, compared to these horrible atrocities that happened over the years. And this led to the so-called Declaration of Helsinki, a group of ethicists and clinicians put together really the first announcement of the key factors in research, clinical research that we still follow today. And it was initiated in 1964, and then they've revised these documents, most recently 2013. Amazingly, the United States and the FDA didn't sign on for the most recent version of these because there was some criticism around who are making low cost medicines available for clinical trials. But be that as it may, the key ideas are all really captured here as probably one of the most important slides of this morning. Declaration of Ethical Standards in Research. This is what this document captures. Awareness and protection for vulnerable groups. Let's say you can't make a medical decision yourself. Are you allowed to go on a clinical trial? That's can you actually sign for yourself? Sign up for a trial if you don't know what you're signing up for. What if you're a prisoner? Are prisoners allowed to, forced, obligated to take part in research? That sort of thing. So this document provides that first awareness and documentation of protection for these so-called vulnerable groups. It ensures that there's some degree of scientific rigor of your clinical trials, that there's some sort of ethics committee review. One of the first documentations of patient confidentiality of information and in real, genuine, informed consent. You know what you're signing up for. Situations where placebos may be appropriate or not, and then how that information is disseminated. And that last point's a relatively important one. Lots of clinical trials are conducted, but if those data are never presented, then people have gone through all this work, people have been gone through extra blood tests or biopsies or what have you, and it does nobody any good. So unless you're actually reporting the data at the end of the day, also fallen short of what should be done as part of that research. This was followed, the Declaration of Helsinki was followed by the Bellrun Report, and this is the US response, in essence, to the Tuskegee Airmen study and other prior unethical studies. And the ideas here, and it's simpler to carry around than the Declaration of Helsinki: respect for persons, which captures the idea of informed consent and autonomy of patients; beneficence, that you're trying to maximize benefit and minimize harm, regardless of the research that you're doing; and then justice, that the benefits and burdens of that research should be distributed. So that patients obviously can benefit, and that also, in a larger sense, the population can benefit. And carries the burden. You have particular responsibilities in taking part in a clinical trial, either as a patient or a caregiver during that study. It's just to ensure that things are done fairly. And these serve as the regulations that have been written into U.S. law. This is the common rule, as it's called. This particular portion of the Health and Human Services regulations really follows this Bellman report, which also is related to the Declaration of Helsinki as well. So what does it mean for research? Overall, it means that this research study, there's a lot of guts that goes into it now. It isn't just, again, let's just give you something and see what happens. This is, we ensure that the study is approved by an institutional review board. Again, a body of people, including clinicians, patients, patient advocates, to ensure that you can actually read the consent form. That's questionable, I'll have to say, in the way a lot of these things are written. That you do get that informed consent. That you ensure that you understand the full extent of what you're getting into, what's going to happen, and make sure that you're not coerced into taking part or by threatening or bullying in some way, shape, or form. Well, if you don't do this, I'm not going to take care of you. That sort of thing. So that doesn't happen. That cannot happen as part research. And in fact, there's that exact statement in most consent forms that says that you do not have to accept participation in the clinical trial. Your care will not be compromised in any way if you decide not to take part. Almost every consent form has that terminology because it's extra. You do not have to do this. You can certainly just stick with the standards of care that are available. Other things that are important for research in terms of recording information and disseminating that information, you have to be aware of the effects from the clinical trial that weren't mentioned. If new data come back on some people who had a bad side effect, a new side effect that had not been anticipated, well, you actually have to go back and change the consent form, and then everybody who's been on the study has to sign that consent form if they're still on treatment, and new people obviously will sign a different consent form that contains that new information. So we have to update the consent forms as the studies go on. That's what that means. And of course, patient confidentiality in terms of taking of their identity and taking part, or whether they choose to or not. That's important that we respect to that decision making for people who decide to take or not take part in trials. And at the end of the day, regardless of whether you take care of, participate in the study or not, you will get a good standard of care for your condition, whether you take part in the study or not. So what is an IRB? I've alluded to it a couple of times. Institutional Review Board is also called the Independent Ethics Committee. This group conducts the risk-benefit analysis, say whether the study should be conducted in the first place or not. So for example, if an IRB received a protocol and said, I want to study 5-FU, 5-fluorouracil, commonly used chemotherapy drug, I want to study that in sarcomas. Well, the drug doesn't work. So that's something that scientific review and an ethics committee, if it somehow snuck through scientific review, would say, no, that's not appropriate. The risk benefit is not in favor of your conducting this study. And the IRB should allow a diversity of people to have a voice at the table. Turns out that a minimum number is 5, and one must be a scientist and at least one non-scientist for this group. So even small institutions, small hospitals can have an IRB, and most, nearly all of them do. Nearly, at least the vast majority of decent-sized hospitals will have some sort of research going on in the need IRB. And they're responsible for content and the updating of consent forms. And now some of the new issues that have come up around conflicts of interest. If the physician is being paid to, or the institution is being paid to actually conduct the study, just how are they conflicted? Are they allowed to take part in the study, or do they only allow their colleagues to actually conduct that research? Other things that are arising now are things along the lines of big data. We have genomics that can sequence the whole tumor, and from sequencing the whole tumor or your whole blood, they can almost, it's amazing the accuracy, they can actually identify individual people based on your sequence just by figuring out links between the genome and ethnicity and where people live. They can, so what do we do to ensure confidentiality of information when these big data sets are being collected and studied as well? So that's a big challenge, and different institutions are handling that in different ways. So here are a few examples of questions that may constitute a clinical trial. For example, which anti-nausea medication is better on dansitron or polonicetron? How do you measure nausea? Do you use a patient score? Do you record how many times people actually vomited? How often do you follow up to find out how people are doing? If you just check people once a month, you check them with phone calls in between visits. How often do you check? How much of a difference do you expect in between one treatment and the other? That determines how big the trial has to be. How many people do you need to show a difference between one treatment and the other? How long will that take? How much does it cost? And then at the end of the day, if it's going to be a 10,000 patient study that costs, let's say, $5,000 a patient, that's already a $50 million trial. And is it really worth doing the study in the first place? So all these sub questions factor into whether you actually conduct this kind of a trial or not. So here's another one. Here's another trial, say it's a combination of two drugs. If you add doxorubicin to temsirolimus, mTOR inhibitor, is that better than giving doxorubicin alone? And so number one, this is the case of the scientific review portion of the trial. Do you have any information that the two drugs actually might do something together? Will it be additive? Will it be synergistic ideally or not? One of the issues with both of these drugs is they can that cause bad mouth sores. So you're going to want to really watch that as a potential side effect on the treatment. What are the doses of the two medications that you actually use together? That ends up being a separate type of trial. Again, what type of difference do you expect between one treatment and the other treatment? That again determines how big the study has to be, how much it costs. And do you think the FDA will end up approving the study if you show a significant difference based on that difference that you're trying to show? It also figures into whether you do a study. And at the end of the day, do people survive longer or do just as well if you get one treatment, two treatments together, or let's say one treatment followed by the other? All those are questions which would help you decide or not whether you want to conduct a research study like that. And so that brings up the types of clinical trials you hear these all the time and what you're signing up for potentially, especially for treatment trials, phase 1, phase 2, phase 3, phase 4. Phase 1, this is oftentimes the first time a combination or medication is being tested in people. But more and more, this oftentimes refers to combinations of an existing drug added to a new drug. So we know what the side effects of the first drug are. Again, let's say doxorubicin. Now you're adding something to it, and you're just trying to figure out just how much of that second medication you can give along with the standard medication doxorubicin. And then what ends up being the dose and the schedule of the drug moving forward. You try and figure that out and come up with the dose that you want and schedule of the medications that you can then move forward. And then phase 2, the next step is to find out, well, as one of my professors told me, it's with an analogy to hunting is can your dog hunt? You know, can you, if you go, shoot that goose out of the sky, that can your dog retrieve that for you? So does the drug work at all, or is it looking promising in any way, shape, or form according to the rules that you've defined in the study that have been looked at by the scientific review committee, looked at by the IRB? They've all agreed that it looks like a reasonable study to do. Does the drug actually work or not? This is a common stumbling point and stopping point for either a new drug moving forward or a combination moving forward. A good example there is osteogenic sarcoma, osteosarcoma, where we've had very few drugs approved despite many, many trials looking at new agents. Phase 3 then is the new treatment, any better than the old treatment. This is one where you may run into placebos most frequently. Is there no therapy that's useful to test against the other drug? And again, it's oftentimes an A plus B versus A alone sort of study. The idea is that A plus B is probably going to be more toxic than A alone, but is it any better? And this is what we're always trying to balance when we're conducting a trial like this, because oftentimes somebody won't get the new medication at first. They may have gotten it in phase 2, but if a group of patients have gotten it in phase 2, but you may not get it in phase 3. And it brings up ideas such as if you didn't get the new medication at the start of the study, well, maybe you would get it later on. So there certainly are studies that's called a crossover design, where if you only got A instead of A plus B, that later on you could get B. And that's an important study design concept that frequently is used these days. So you may not get B at the beginning, but you'll get B at some point by taking part in the study. And so after all of that, drugs will oftentimes, the data will be presented to FDA or other regulatory bodies, and then that leads to ideally approval of an agent. And then you can also still conduct research on those drugs afterwards. And this would be a good example. A good example would be looking at the immune checkpoint inhibitors, nivolumab, pembrolizumab, ipilimumab, that sort of thing. Those have all been examined now in sarcomas after approval of the drugs in other diagnoses. So we already know the dose and the schedule to give. We just want to find out if the drugs work. And then you can still ask questions. Since we're all getting older as a population, for example, does the drug work just as well at age 75 or greater than it did at or below age 70? Are you studying a different population, for example? Or, for example, if you have a little bit of kidney problems, chronic renal failure, will the drug work the same way? Those are all those could be phase 4 sorts of questions as well as phase 2. All right, so how do I find clinical trials? The best place to look is clinicaltrials.gov. This is the key website. There are some others as well that you can pay to have your study posted, but this is a great place to start. And here's the website, and it's sponsored by the U.S. National Library of Medicine. Great source for PubMed as well. It's another great resource for looking at articles on your diagnosis of interest or your question of interest in a medical sense. And it has a list of criteria for your study to look at. So is this one recruiting? Is it open now? Do you want to take a look at all studies? What's the diagnosis? You can type in sarcoma there, and then add other terms. And then country, if you want to, it actually does list international trials as well as just US trials. You can also zoom in by state or city with a radius around your hometown to find out what's available in that sense. So once you do that, so for example, typing in sarcoma, 482 studies. I typed in here also looking for studies that were recruiting and not yet recruiting, not ones that are closed. And when I did that, I came up with these 482, and it lists them all in a tabular fashion, tables with 10 or 20 of these trials per page, and then you can begin to explore them. If it's too many, then you can add more filters, again, maybe geographic distribution, or if there's a certain medication you're looking for, or a certain target. I've had, as you heard from Jonathan Trent's talk yesterday on precision medicine, if you had an ARID1A mutation in your tumor, maybe there's a study that's looking at people who have an ARID1A mutation. So you can zoom in on these clinical trials to find out if there's anything that might be relevant based on your very specific criteria that you give. So very, very useful in that sense. And then if you zoom in on leiomyosarcoma with active trials, then you do see a number of studies that pop up. In this case, there are about 30 trials that pop up, and then you start seeing the places where these are being conducted. There's a study here with a drug from a small company in New Jersey with the carbazine and leiomyosarcoma being done at 1, 2, 3, 4, 5 sites in the U.S. And then here's another study here. This one is in Korea. So you probably want to zoom in unless you're, have your flights on Korean Airlines frequent flyer miles on that. You probably want to look for trials that are a little closer to home. So you can choose active or going to be active trials, not yet activated. Look for your specific diagnosis, but sarcoma oftentimes is enough. And then again, you can focus on your neighborhood within a certain range of your zip code. And it gives you contact information. Importantly, you click on each of these links, and it'll give you a contact person. It might be the physician themselves who are running the trial, or one of the nurses or nurse practitioners or physician's assistants, or data managers even, to give you some more information on that trial, so that way you can get more engaged in research. Any questions that you want to ask then? Is the study still open? Might I qualify? What does this mean in terms of time commitments? You can at least get some sense of what the scope of the trial might be. Can you tell me something about the side effects? Could they send you a consent form, for example, to take a look at? And then when you do actually have a consultation to take part in the trial, are there other alternatives I should be thinking about? So that's just other things I should be thinking about that my doctors who have taken care of me so far haven't talked about. So in any case, clinicaltrials.gov is the key place to go. The other important point that I hope you've seen from this brief presentation is that really there are a lot of protections in place. We are really trying to do this work carefully and well, and there's auditing that goes on to make sure that that does happen. And you will see places like the NCI that goes back to check in on the different cancer centers or on hospitals to ensure that the data is being collected properly, that the studies are being run well. In fact, this happens in almost all industrial trials as well, when run by industry. They have their own groups of people who will go back and audit the data and make sure the trial is being done properly. So there are a lot of protections in place. Still, you have to be your own best advocate, I'd have to say, and seek out experts like Bob Benjamin and what they do. It does make a difference, especially for cancer. Of course, group here does a great job in disseminating information. So with that, I will stop, I believe, and thanks very much for taking this to speak with me today.
Does anyone have any questions? Anyone have any questions? Start a little.
In many cases, the trials are a patient's last or best hope of getting cured. Two questions really. What is the good of a placebo? If you're going in there already with a problem, why would they put you on a placebo? The other question is simply, if you are on the placebo, you're told that at a certain point, you will be changed over. Why does that have to reach a 20% growth before they'll even change you over?
Yeah, it's all very, very good questions. And if there's somebody who's in a bad enough situation where 20% growth of a tumor, answering the second question first, 20% growth might compromise somebody, then you shouldn't put that person on a trial. But we still do those. The placebo-controlled trials are done in some randomized trials, randomized phase 2 and randomized phase 3 trials. It's because we just don't know if there's really activity of the drug. I use that 5FU example as a little bit of a false example. We know this is not a very useful drug, but people can get plenty of side effects and very little benefit from certain agents. We certainly have had that experience again in osteosarcoma is a good example. We've had trial after trial after trial of new drugs, but nothing has really been shown helpful. So we put people out by causing more side effects without clear evidence of proof of benefit. We go into those studies thinking there may be some benefit, and this is where the FDA actually is becoming more open to the idea of not having a randomized trial to support an approval of a drug. And then you may run into another good example recently was olaratumab. Here's a drug that wasn't terribly toxic. Tried to add that to doxorubicin in this randomized phase 2 trial, showed evidence of benefit. People were in that particular trial lived on average a year longer. So we went ahead and did the phase 3 trial because we still weren't sure whether the drug worked, but there was no difference between people who got olaratumab and those who did not. So the problem is that the smaller trials that we do don't give you definitive information, unfortunately. So it's a complex question. Fortunately, we're able to avoid placebo entirely. In some cases, if there's a clearly active agent, we can just run to FDA and say, this drug works. How could you do that? Well, you have the definition of how people have done over the years and with that same diagnosis. And let's say you know that on average, people only live 6 months in this particular situation, and then you've got a group of 20 or 30 people you've treated with that exact same situation, and now they're living 2 years. So on average, those sorts of data are enough to oftentimes allow for approval of the drug, at least initially by FDA. So they're being more flexible. Clinical trial people are being more flexible as well. We really do try and avoid the placebo trials unless it's absolutely necessary. And we try and do it in a situation where people won't be compromised if they don't get the medicine. But it's still less than ideal. We wish we could know just from treating everybody how whether the drug works or not. But at least some people have to not receive it to get some sense of that at some point for these sorts of comparative trials.
How is the focus on genetics and personalized or precision medicine affecting the structure of clinical trials? I know I've heard about the N of 1.
Mm-hmm. That's a great question. The question is on the use of what John Trent was talking about yesterday on precision medicine, using the genomic testing and so forth to change how clinical trials look. It certainly does that, in that certain drugs only work if you have a mutation in a particular gene. So all the drugs that you talked about yesterday on GIST, for example, those are all defined by a specific hit mutation. And we've had that famous DA42V GIST mutation. You really didn't benefit from any of the old drugs, but these 2 new ones, ripretinib and avapritinib, they're home runs. And in fact, they'll probably end up getting 4th-line approval from those days, at least in part. They actually are moving forward with randomized trials as well, both companies that make those drugs, but it's all defined on mutation. It turns out that there just aren't that many mutations that define treatments in sarcomas. Lung cancer is very different. It's a part and parcel of what we do for lung cancer, but the chance that we actually find a mutation that helps people and chooses a treatment for something outside of GIST is strikingly low. I would call it 5% or fewer. So yes, we love it when we can find an alteration and link that to a treatment, but knowing that you have a P53 mutation in your tumor, we actually don't have treatment for that. And a lot of the mutations that you'll see on these sheets don't have a specific mutation attached to them. So, so because of that, it makes it, just because you have the data doesn't mean you actually have a treatment. And so, for example, there are in each cell something like 550 kinases. KIT is one of those, and just kinases, these are kind of the electrical wiring system of the cell. And any one of those can be mutated in any cancer, at least in principle, but we certainly don't have 550 drugs to hit each one of those. So if you do find a mutation in one gene or not, we may not have a drug for it. So that's the other thing. But we are increasingly trying to do trials that are molecularly based where it makes sense. When we don't have that much information, then it's just being done at the level of, let's say, a specific diagnosis. But sometimes that molecular testing helps with the diagnosis. We certainly see in at least 5 to 10% of people where the molecular testing will change the diagnosis for somebody. This is kind of a separate question, but as far as I'm concerned, it should be done in pretty much everybody where we can, and hopefully we'll see increasing use of molecular testing. It just helps to reinforce there's already a difficult question, what's the diagnosis and what's the specific subtype of sarcoma that you're dealing with.
Does natural history data collection for patients, does that impact trial design? Is helpful?
That's a great question. Does having historical data on patients drive clinical design? Absolutely, for just the reasons I was talking about. If you know how a group of patients did historically, and you can prove that is consistent, then you've got a baseline that you're starting from, and then you don't need to necessarily do the randomized trial. If your drug really shows evidence of benefit above and beyond what's been seen over and over and over again over years, then you can use those data as sufficient for regulatory approval. So it's an important point.
You mentioned Alyssa.
Yes, alertment.
I know that they're not using it now, but it was a factor in some people.
We don't know.
I felt like it was a factor for me, so
Mhm.
it's not making it, or are they tweaking it, or is it more of a cost thing where they found that it wasn't working enough to continue?
It wasn't working enough for the FDA to give authorization for it to be used. So I still have a couple of people who are just on the alertumab portion alone as well. We just haven't stopped because there's still a existing supply of the drug, but going forward it won't be available because there was no difference in terms of outcomes for people who received the drug or not. That was a much bigger trial. If you go back and look at the older trial, it turns out that, of course, a mix of patients goes on the trial in terms of the different diagnoses. So some mix of people with liposarcoma, leiomyosarcoma, synovial sarcoma, rhabdomyosarcoma, what have you. If that mix is different from one treatment arm to the other one, it's one of the unintended things that you don't really track for when you're conducting a trial. If that's different, then you can also see a difference, because if you happen to have a group of patients with slower growing cancers, then if more of them are on the treatment arm and fewer on the placebo arm, then they're going to look like they do better. But in actuality, it was just the biology of the tumor that you were watching. I think that's what the problem was with that randomized phase 2 trial. In fact, that's called a false positive, a type 1 error. And the study had, I think it was a 20% chance of having a false positive result. That's just the way the study is designed. It was only 120 patients or so.
What if you are one of the people that is on it alone?
Then at least for the time being, at least there's at least a stock of the compound that's available. And I've had people getting 40 and 50 cycles of therapy at this point. They're still on treatment.
I guess my question goes more to, like, is it the FDA that says we don't determine that it's working, or is it the drug company that says it's not working enough to, facilitate us?
Also, it's FDA. It's really for FDA approval, which means you're paid for it. The drug company could agree that, well, we're still looking at the data. We still want to do some studies on it. And in fact, they are. They're looking at a gemcitabine combination. Those data are not back. So there still are studies that are out there. And if there is some sign of greater benefit of alertumab with another combination of drugs or another diagnosis, that could still lead to the commercial availability of the drug. But at least for soft tissue sarcomas, alertumab will not be available for the future because the FDA did not authorize its use. there aren't that many side effects, but I guess we were unlucky and had an allergic reaction to it, then that would be considered a bad thing, and even a few people where that happened would be reason enough not to have the drug available. So, yes.
Yeah, you kind of mentioned patients being their own advocates and being able to look up trial information. Any words of advice for patients who identify something, maybe who are being treated in a community setting, to go back and have conversations with their oncologist about trial options?
Yeah, it's certainly something to mention, and I think a lot of the people who specialize in this area are aware of different trials, but not everybody can know everything. I know 2 hospitals have the same trials open, so I think it's always good. So, I have a number of folks come to my office and they'll have printouts of some of these trials, and we go through them. So I think it's good to do that. Certainly open to the conversation. And, dialogue is better than a monologue.
What's the standard for whether something is approved by the FDA? I'm listening to going back here, and it seems like some people in the study had some rashes, and based on that, the FDA may not have approved it. I mean, there's got to be a risk-benefit ratio.
That's
here.
right.
I can personally tell you, I take a couple rashes to get rid of what I got.
Yeah.
So what exactly goes into the analysis, the bottom line analysis? Is it the cost per patient? Is it the terrible side effects for a percentage of the patients? And a second question is, you use the term small study.
Mhm.
For sarcoma, small study might be X number, and for lung cancer, small study might be X times 10.
Mhm.
So how is that defined, and how is that analyzed?
Answering the second question first, every study is different, and it really depends on the clinical scenario that you're looking at. But the FDA, let's say with olaratumab, they're looking at harder endpoints like how much time went by before people got worse by scans, or how long did they live. That's ultimately the one that you want to use if you can. It doesn't always hold up. Say it's prostate cancer, people live for a decade or longer with metastatic prostate cancer, so it's really hard to use overall survival. You'll never get the study done, at least in your lifetime. So we have to use other endpoints, and one of those is how long did it take for people to get worse on average. And in the bigger olaratumab study, that was exactly the same between whether you got 2 medications or 1. And as a result, there's no point in giving the 2 medications because the 1 gave you the same result. So that's the reason that FDA did not give authorization for that second drug.
So the FDA could basically say, we're going to shut this off completely because it didn't work to our standard, even though it helps other people.
We don't know that, so I mean, it's not entirely clear. If it's not being done as part of a randomized trial, it's really hard to know. What was how much did that new medication contribute to the response? How much was the old medication? There may be the occasional person who does respond to just the new drug, and that certainly does happen. But since the data were so similar to one another, at least at first pass, there wasn't, there was no reason to give the 2 medications. Now, Lilly, who makes olaratumab, are going back and they're trying to find out if there's a specific diagnosis or a specific clinical scenario, or maybe a specific genetic pattern of the tumor that might predict for the drug helping people. The drug blocks something called PDGF receptor, and the PDGF receptor, actually they use that as a marker in the trial. They tried to use that marker to find out if people did worse or better based on whether they had that marker on their tumor or not. And interestingly, if you have the marker on your tumor, you did worse. Kind of, it's counterintuitive, but it also just means that the data don't fit together. There was one other bit of data that FDA would use to say it's just not worth giving approval to that new compound. But now the subsets have to be looked at. It's several hundred people. Now you can go back and look at all the leiomyosarcoma patients, all the epithelioid sarcoma patients, and maybe somebody within that group, some small subset benefited. And now that becomes a new study for more research.
How do they decide the people that are going to be making those decisions on the FDA, and can you protest their decision?
So if it's a new compound, the drug usually faces what's called the ODAC committee. It's the Oncology Drugs Advisory Committee. at FDA, and that consists of typically about a dozen or so experts in the field of oncology, as well as one patient advocate. So there's usually something like 13, 14 people who sit on this panel, and they give advice to the FDA whether the drug should be approved based on the data. And the patient advocate is the kind of the key person representing that patient population, and they'll oftentimes everybody's allowed to give a statement when they give their vote for a particular compound, and they give the rationale for their vote. So that's all available there. It's hard to change the decision once it's been made. I don't know that that's really been done. There have been, for example, one good example was the use of bevacizumab Avastin in the treatment of breast cancer. And there were studies that were some earlier studies were positive, larger studies were negative, and there was a big kerfuffle when they were not given authorization to use the drug in breast cancer. But that's held. The drug was initially approved, and actually the approval was withdrawn because the larger studies that were conducted didn't show benefit. So it is possible to have. There is definitely a patient voice that takes part in that authorization, and it's taken seriously. The FDA panel that ultimately says yes or no.
One more question. Is there ever a time where the drug or whatever is disapproved here, but another country continues to use it, so people have to go there?
Yes, that's definitely the case. So there certainly are compounds that are approved in Europe or in Asia that are not approved here. And a great example is MTP, rambl tripeptide. This was shown beneficial in a randomized trial, but the data were presented in a clumsy fashion to the FDA, so it never got approved. But it was approved in Europe and in Asia. So it's a standard of care and for osteosarcoma in Europe and Asia, but we don't have the drug.
And we have time for one more question.
I'm wondering about, and I'm not even sure how to express this. What is the difference, if any, between the way decisions are made for drugs that might affect a large number of people and drugs that might be helpful to little orphan diseases?
So the bar for approval is different, and they still try and do randomized trials, even if it's a very small number of people. Oftentimes with the crossover design, there's a laboratory where I work, they came up with a compound that helps to treat kids with a movement disorder, basically a muscular dystrophy of sorts. And they were able to present enough data that there was improvement in their movement scores, that the drug was approved on phase 2 data, in essence. So the bar is different depending on the diagnosis and the tools that you have to show that people are doing better. But they're certainly open to the idea, even with orphan diseases, ultra rare diagnoses, which a lot of people have in this family members have in this room, and those certainly are taken into account. And the FDA has actually had a series of meetings over the years, over the last 10 or 15 years, on how do you actually conduct a clinical trial properly in a super rare cancer. So they're aware of the situation. FDA are more and more open to alternative ways to getting drugs authorized and approved, at least in a preliminary fashion. Olaratumab was approved preliminarily based on early data, just to get it out there, because it looked like the survival difference was real. And then it evaporated, so it's been withdrawn. So there's a open-mindedness to FDA now that didn't exist, let's say, 10 years ago, 10, 15 years ago, which is, I think, to everybody's benefit. Thanks a lot.
Just want to thank Dr. Maki again. I don't know how much you know about him, but he is a very famous sarcoma oncologist and been my mentor for over 15 years, just like the next Bob. So we should have a Bob sarcoma, So we have Bob Maki, and he's also a doctor. So he is a doctor, so just like Dr. Trent, and both Dr. Maki and Dr. Benjamin and all the doctors here, they're taking time out of their busy weekends. They're not getting compensated for for this, and they're, spending their time and money to come here to educate you. So just want to give another round of applause. Thank you. I'm going to introduce the other famous Bob Robert Benjamin, who is very famous in sarcoma. He's been my mentor also for many years. And it's hard to say, so Bob was at MD Anderson, and Bob Benjamin was at MD Anderson, and Bob Maki was at Sloan Kettering at the time when I was in training, and get different opinions. So I would ask Dr. Benjamin, I would ask Dr. Maki, I would ask Dr. Dimitri at Dana-Farber, so it was really get different opinions as you see. And Dr. Benjamin came last year and had a really good response. We had good feedback from him, and he has been at MD Anderson for a long time, and he has led to the discovery of the use of chemotherapy in sarcoma. So Dr. Rubison, he was there to invent it, actually. So he didn't invent the drug, but he did invent it in sarcoma. So really happy to have him here as well. And I can go over all the, his curriculum and all that, but he's just a fantastic person. He's trying to retire, but I don't think he's doing a very good job. He's excellent in everything except for retiring. So we don't really know the status of his retirement, but they say he's retired. Thank you so much. He's going to talk to you about chemotherapy.
Thanks, Gina. Thank you all. And I guess I've probably been doing this for too long, so I'm Bob 1. Doesn't have Robert on my name tag. The only person who calls me Robert is my wife. But I'm Bob. I'm Bob 1. He's Bob 2. And the standing sort of overriding theme is Bob is never wrong. Okay, here are my disclosures. The only important one is that I always use the word adriamycin because it existed for years before doxorubicin, and that's when I was studying the drug, so I stick with what I know. So I'm going to tell you a little bit about chemotherapy, or maybe too much about chemotherapy. I'm going to give you too many details. You don't need to learn them all. And I will give you some of the data on the olaratumab that was just discussed in this context to show you how it got approved and why it got killed. So chemotherapy in general, what it really means is treating with drugs as opposed to surgery or radiation. But it's come to mean cytotoxic chemotherapy. It can be given either systemically to the whole body or to a specific area. But when we talk about it now, we distinguish chemotherapy from immunotherapy or targeted therapy, although they really all are chemotherapy. Cytotoxic chemotherapy is a selective poison. It's designed to kill cells. The theory behind it is based on killing more cancer cells than normal cells. So the host survives and the cancer dies. What are the side effects? The side effects of chemotherapy are terrible. You wouldn't wish it on your worst enemy, although you might wish it on your best friend if your best friend needed it. Because what's important is killing the cancer. So it just happens that sitting next to Dr. Maki over there is Dr. Robolino. And Dr. Robolino was my patient 30 years ago when she had an osteosarcoma in her leg and got cured. And so after more than a year of dealing with all of these side effects, she's here and practicing medicine in Miami. And so it's wonderful to have her here. So what does chemotherapy do? It causes fatigue and nausea and vomiting and hair loss and all of these terrible things, most of which deal with damage to relatively rapidly dividing cells. And rapidly dividing cells seem to be more sensitive to the non-specific effects of chemotherapy than more slowly divided cells. But that's not always the case. And some of these other toxicities, like damage to nerves and heart, aren't rapidly dividing cells, but they're still targets for chemotherapy. And similarly, some cancers, as I'll show you, that are not rapidly dividing are targets for chemotherapy. So it's not as simple as just rapid things get killed and slow things down. So how do you manage the side effects? Well, I think one of the things that's been a remarkable improvement over my career has been in the treatment of nausea and vomiting. Nausea and vomiting is not a life-threatening condition, but it makes you miserable. And we have much better anti-nausea drugs now than we used to have. And most of the time, we can't totally eliminate it, but we can make it pretty tolerable. And similarly, we have, at least for white blood cells, now good growth factors which can counteract some of the side effects of the chemotherapy. So it's not that the blood counts don't go down. We can make them not go down if the chemo is pretty mild, but with the chemotherapy that we use, blood counts still go way down, but they don't stay down very long. And so the risks of infection, which is the real risk of a low white blood count, are markedly diminished. You can get mouth sores, which are, and anywhere in your GI tract sores, which again are miserable. There are ways of modifying the treatments to minimize those effects, but you can't always completely take care of them. We found that a drug called palifermin can be helpful in severe cases to allow you to give the chemotherapy that's needed. There's always the risk of infertility, but it's certainly not an absolute risk, as Dr. Robolino's daughter will indicate. There is a risk of causing second cancers. But again, you got to cure this one before you have to worry about getting a second one. And then there are strategies to deal with some of the other problems. But the one that I will just sort of emphasize, because it's what I've studied for my entire oncologic career, is the cardiac toxicity of adriamycin. And cardiac toxicity is something that scares most doctors totally. They're so afraid of causing heart problems that they undertreat with the best drug that we have. And there are ways of minimizing the heart problems, either by changing the schedule of administration, using continuous infusion therapy, or using a protective drug called dexrazoxane. And the real thing, the most important thing is you have to think about it when you're starting. Don't wait until you run out of adriamycin and then say, oh, gee, I guess we can't give any more. Because if you had had the forethought to start cardioprotection from day one, you could have given twice as much. Now, hair loss, people think of toxicity. I personally don't think of it as toxicity because I've lived without it for years. But also, you know, I happen to have a thing for bald women. A pretty bald woman is a pretty woman. You don't worry about whether she's bald or not. And again, you never have a bad hair day. But the single most important toxicity is failure. So if you worry too much about all of these other little things, which are, as I said, they make you miserable, they're terrible to have to deal with, but you lose sight of the fact that the most toxic thing is the cancer, and you can't say no to that. So keep your eyes on the target. You know, figure out, are you getting, you want to get the maximum benefit from your treatment. And if that means you have to give high doses of drugs and have toxicity, I mean, that's what oncologists are for. We learn how to take care of patients with leukemia who have no blood counts. We can manage a patient with a week of low blood counts with a sarcoma. So what's the purpose of the chemotherapy? It's to kill cancer cells. I told you, it's cytotoxic. That means killing cells. But how is that manifested? And that comes to some of the questions about the clinical trials. And I apologize in advance to the radiologist who's going to speak next, because I'm going to give half of his talk to try to explain some of this. The textbook says that if you kill the cancer will shrink and it'll get smaller, and you can measure that, and it's easy. The problem is that many sarcomas forgot to read the textbook. So how do you define this killing of cancer cells? And that gets back to the question the gentleman raised in the back, who said, you know, if I'm on the placebo, why does the tumor have to grow 20%? We also talk about prolonging survival. That's something that came into the way we evaluated drugs in the treatment of cancer when cancer drugs were given only to patients who were about to die. And we continue to use it, and I think it's absolutely the wrong endpoint. So let me give you some examples. I don't know if I can point. So lungs are supposed to be dark on an X-ray. All that white stuff that's in there happens to be metastatic synovial sarcoma and doesn't belong. And this is a patient who was a young man. He actually came to us from Europe back in the 80s, and he flew over on the plane using supplemental oxygen because he couldn't breathe, because his lungs had literally been replaced by cancer. He was about to die. He'd never had chemotherapy because he had been told over there that chemotherapy doesn't work for sarcomas. So these are a picture of his x-rays, and this is what you call the typical example. And I'm lying through my teeth. This is one of the best responses I've ever seen. And in his case, it really meant the difference between life and death immediately. And we allowed him to live another couple of years. Now, if we'd known how sensitive his tumor was to chemotherapy, if he'd gotten the chemotherapy when he was first diagnosed, he'd still be here. He isn't. This is a CAT scan of a patient with a GIST. And the big,
Red dot.
is there a pointer?
Yeah.
There it is. Got it. Okay. This big thing is the tumor. That's a GIST. This is the tumor after treatment with imatinib. And there are two things that you see about it. There's a difference in the tumor size, and there's a difference in the characteristics of the tumor, the way it appears. The one over here is bright, whitish. The one over here is dark. That has to do with what we call contrast enhancement. But it deals with a quality of the tumor. Live tumor cells take up contrast. Dead tumor cells do not. So although this tumor is smaller, the major difference that you see is that it looks like it's all dead. So now, does everybody, by the way, does everybody agree that the tumor on the left is bigger than the tumor on the right? Is there anybody who thinks that they're really the same size? Okay, so here comes the problem with the clinical trials. And this happens to be, it's just the only waterfall plot that I had a slide up that I could pull in real quickly. This is what's called a waterfall plot. Each of these bars represents the percentage of shrinkage of an individual tumor in an individual patient. And this is a series of patients. They happen to have desmoid tumors and they were treated with imatinib, but that's not important. So here, you see that this tumor has decreased almost 50%, and this one 40%, and this one almost 40%, etc. These have decreased all more than 10%. These have been decreased a little bit. These have grown a little bit. These have grown a little bit more. These have grown still more. Okay? Now, nobody in his right mind, other than the person who designs clinical trials, would think that the size of this tumor and the size of that tumor are the same. But in fact, the way we measure response in chemotherapy studies is a partial response requires a 30% shrinkage of the maximum diameter of the tumor. So these patients are responders. Progressive disease requires a 20% increase in the size of the tumor. So these people are progressors. And everybody else between these yellow lines is no change. So the people who run the trial think that this patient is the same as that patient. And they're absolutely crazy. So here's an example of tumors getting smaller. The tumor here is the entire abdomen. Tumor here is a smaller portion of it. What's left is this little nubbin. This is a patient with a desmoid tumor treated with adriamycin and dacarbazine, highly toxic chemotherapy. And you can look at the dates. So this is a slow-growing tumor, not rapidly dividing cells, highly sensitive to chemotherapy. Here's another example that's pertinent to at least one of the people I met this morning. It's a patient with myxoid liposarcoma because trabectedin happens to be particularly active in myxoid liposarcomas. Whoops, how did I do that? Sorry. I got carried away. So the first thing you see in the response from the x-rays at the right are that the tumor loses its contrast enhancement. And then it shrinks. But if you actually look at the activity of trabectedin in myxoid liposarcomas, it's effective in about 80% of patients. But the ones who qualify for a partial response are only 20%. It's not that it doesn't work in the others. The others are working just as well. They just didn't learn to shrink properly. And here's the same drug used preoperatively, and you can see what's happened. The MRIs at the top show highly contrast-enhanced tumor losing its contrast enhancement after only one course, still more loss of contrast enhancement, but the tumor size is absolutely the same. Initially, the tumor is full of tumor cells, and when it was removed surgically after the 4 courses of chemotherapy, there are no tumor cells, but the tumor is still there. So I think clinical trialists have blindfolded themselves and made it impossible to determine the effects of therapy. But a good sarcoma oncologist can tell you whether you're getting better or not. So now let me tell you a little bit about the drugs that we have, because there are only a few of them. And the first one, and still the best one for most sarcomas, is adriamycin. And this is a drug from the early 1970s. Response rate in a Southwest Oncology group study at 75 milligrams per meter squared, 37%, 40% in my little study. 10 years later, 23%. Now, closer to 10%. It's the same drug, same group of patients. The response rates have fallen markedly. What's the difference? Well, the first difference is in the 70s, we didn't have CAT scans. The only real measurable disease were pulmonary metastases on chest x-ray. And pulmonary metastases tend to get smaller. Now we have CAT scans, we have these big intra-abdominal masses, we have primary tumors, we're looking at an MRI, and they're behaving like the x-rays that I showed you just before. So the number of patients who are called response is far fewer. And medical oncologists in academia are very careful not to want to overcall responses because they don't want somebody to say, oh, you lied about that. What's happening is they're undercalling responses. So same drug, different response rates. It's gotten to the point where response rate, if the most active drug we have has a 10% response rate, that's not a meaningful endpoint for a clinical trial anymore. So we have to use other things. And what gets used now more often is time to progression. And I apologize for showing you a survival curve type thing, but this is the basis for all of the newer oncology approvals, this time to progression. And there was a study performed, a retrospective clinical study performed by members of the EORTC, where they looked back at all of their sarcoma studies over the years. And the active agents that they had were adriamycin and ifosfamide. And the inactive agents were everything else that they'd ever studied. And what they found was if they just plotted a time to progression curve, that's how long it takes you to cross that 20% plus mark. Okay, that's time to progression. At 3 months, for the inactive drugs, 80% of the patients had failed. For the active drugs, only 60% had failed. So there was a 40% progression-free survival for the good drugs and 20% for the bad drugs. So future studies have been looking at, can we improve the rate of failure-free survival at 3 months with our new drug? So here are the old drugs. Adriamycin, my predecessor at MD Anderson, Jeff Gottlieb, added dacarbazine, which was a major contribution. It's not a very active drug by itself. Ifosfamide was discovered in the 80s. The adriamycin ifosfamide combination came next, and finally gemcitabine docetaxel. Those are all of the standard drugs we use for sarcomas. Since 2010, we've had 4 new drugs approved in the treatment of sarcomas, where we hadn't had a new drug approved since 1974. I'm not going to talk about pazopanib because it's not chemotherapy. Hopefully Dr. Trent said something about that yesterday. I am going to talk a little bit about olaratumab, though, because it's used in combination with chemotherapy, so I think that probably counts. But then we have these 2 new agents, trabectedin and eribulin. So don't look at the details. This is for me to make a point to you. Adriamycin, single agent, more or less the same activity across a number of different subtypes of sarcomas. Same thing when it was combined with the carbazine, except it's a little bit better. Again, these are numbers from the 70s that, you're not going to see the same things if you did the study today. Ifosfamide, which is the next major drug that we use, starts showing a difference in different sarcomas. Synovial sarcoma, it seemed to be a little bit more active. Leiomyosarcoma, it seems to be a little less active. And then there's everything else. And it's not true just of our studies. Karen Antman's study showed the same thing, higher in synovial, lower in lyo. Axel Lassen's study, higher in synovial, lower in lyo. Adriamycin, more is better. This is actually one of the few studies which actually looked at in a randomized study giving different doses to different groups of patients. And they showed that patients who got 45 milligrams per meter squared had half the response rate of patients getting 75 milligrams per meter squared. So for sarcomas, if you're using adriamycin, you got to give enough. We looked retrospectively at our data on serial studies with ifosfamide and saw more or less the same thing. More is better, but this was not a randomized trial. This was just sequential trials going along. But so my colleague, Dr. Patel, put together an adriamycin ifosfamide combination, trying to use full doses of each drug. So 10 grams per meter squared of ifosfamide, 75 milligrams per meter squared of adriamycin. We saw in patients with metastatic disease a 62% response rate, and only 11% with progressive disease. Median time to progression was 10 months, median survival 21. These are, again, metastatic disease, and this is the median. So that means half of the patients live longer than that. But survival is a composite endpoint. You're my patient. I'm treating you with my new study, this initial therapy. You get a little response and then you fail. What am I going to do? Tell you to go home and die? Hell no. What I'm going to do is every trick that I can pull out to keep you alive. But on my study, all of those tricks add up and get counted in your survival. So the better I am at treating you after you failed my first study, the better you will be at surviving. And that has nothing to do with the treatment from the first study. I'm going to get back to that. So the adriamycin ifosfamide combination got studied in Europe in a randomized study by the EORTC. The primary endpoint of the study was survival, and for that reason, we did not participate in the study. But what the study showed was the response rate was doubled, was low in both arms, but it was double in the combination. The rate of progressive disease was cut in half. the time to progression was longer by 50%. And the conclusion was it was a negative study and that adriamycin was as good as adriamycin ifosfamide. The reason for that is the stated endpoint of the study was to measure survival at 1 year. And the statistical construct of that study was to improve survival from 50%, which is what they had obtained in any number of prior studies with adriamycin alone, to 60%. And they had a sufficient number of patients to show that that 10% survival improvement would be statistically significant. Well, they got 60% in the adriamycin ifosfamide arm, but in this particular study of 200 patients, the adriamycin patients were 51%. And because they couldn't show that there was less than a 5% chance that 60 was better than 51, they concluded that they are the same. So the conclusion was it did not significantly improve survival. So in clinical trials, the devil is in the details. But interestingly, when the French looked at a large series of patients from their database, a retrospective clinical study, that the patients who had combination chemotherapy clearly lived longer than the patients who had single agent chemotherapy. But that's because instead of 200 patients in each group, they had almost 800 patients in each group. So the difference is all statistical nonsense. So let's look at olaratumab. A 129 patient randomized phase 2 study. The primary endpoint was progression-free survival with a p-value of 0.2. Now, normally, when we're trying to look at something being statistically better than something else, we use a p-value of 0.05. Sometimes it's 0.01. That is, we want to be absolutely certain. But this was a tiny study. They were just trying to get a hint, does olaratumab possibly improve the progression-free survival? And then they threw in this secondary endpoint of survival. So for progression-free survival, what they found was that there was a 2.5 month improvement with the olaratumab combination compared with doxorubicin alone. 2.5 months. When they looked at overall survival, there was more than a year of benefit of survival from the patients. So now they're progressing 2.5 months later, but they're living another 16 months extra, and they're relating that to the olaratumab. Now, first of all, the study was not designed to show that there was a survival benefit. Second of all, there is this aphorism. If it looks like it's too good to be true, it probably is. But in the phase 2 study, in the paper by Dr. Tapp and his colleagues, they showed very clearly why the survival was better. And I don't think it's related to the different patient mix as much as to what happened afterwards. Remember, if you're good at taking care of the patient after he goes off the study, it's going to live longer. And what they showed, and it's in the paper, was that the patients who got treated after they failed olaratumab got more good therapy. They got more treatments and they got better treatment. It's not randomized because at that point it's just dealer's choice. It just happened that the patients who were on the experimental arm of that first study got better treatment afterwards. So they lived longer. So here's the presentation from ASCO this year where they repeated the study with more patients and made sure of everything and did a formal phase 3 comparison. There was no improvement in progression-free survival. If anything, it was worse. It was better with adriamycin plus placebo than it was with adriamycin and olaratumab, but not by much, month and a half. And there was no difference in the survival. So the reason that olaratumab was removed from the market was the FDA said, given all of the data that we have, we would not have approved this drug in the first place. We gave it approval based on a very tantalizing preliminary observation, and we were wrong. So let's look at the other cytotoxic drugs that are approved. Trabectedin, I showed you already, it's a home run for one small specific subtype of sarcomas, myxoid liposarcoma. But it does help in other sarcomas. And the study that was done, before I get to that, forgot about Gemtax, which is our best second-line therapy. The reason for this one was the death of olaratumab. So gemcitabine is an active drug. Hasn't been approved for sarcomas, but clearly has activities. And it's approved for other things, so we can use it. Dr. Patel did the first phase 2 study that showed improvement. Marty Hensley at Memorial combined gemcitabine and docetaxel in uterine leiomyosarcomas predominantly. There were a few other leiomyosarcomas thrown into the picture, but they were almost all uterine. And she showed very, very impressive results. Now, problem, docetaxel is an inactive drug in the treatment of sarcomas. It's an inactive drug in the treatment of leiomyosarcomas. So why should gemcitabine and docetaxel be a better way of using it? Frankly, I thought it wouldn't be, and I was wrong. Bob Maki did the study with SARC, and we used an interesting clinical trial design comparing gemcitabine alone and gemcitabine and docetaxel. And we looked at a composite endpoint, not just response rate, but sort of response plus prolonged stable disease, which would capture those people who benefited but we couldn't define as responders. So gemcitabine with docetaxel was better than the gemcitabine in terms of response rate and success rate. When we looked at the histologies, leiomyosarcoma was not the most active subtype. We actually saw more activity in unclassified pleomorphic sarcoma, and there were some strays in other subtypes. And I point out the pleomorphic liposarcoma group, which is an interesting group because that's the most malignant of the liposarcomas. But there was clear-cut improvement in progression-free survival and survival. So again, why are we showing a survival benefit? Because this was done in failed patients. They were much closer to death if you got any benefit. It's like that guy with the lung full of tumor that I showed you in the beginning. If you get benefit in a patient who's dying, that benefit is immediately translated into a survival advantage. If you get benefit in a patient whose metastatic disease has to be found by looking very carefully at a CAT scan of the lungs, that's not going to translate into survival. So now, the new drugs, trabectedin. Trabectedin is an interesting compound. It comes from the sea squirt, and it was shown to have activity in sarcomas years ago. It's been approved in Europe since the early 2000s. It was not approved in the United States. The same data that got it approved in Europe didn't get it approved in the US at that time because the US regulators were looking for a survival advantage and couldn't get it. So there was a large study put together, 518 patients of trabectedin versus dacarbazine, looking for a survival advantage. Didn't happen. They all lived the same amount of time. But progression-free survival was 4 months in the trabectedin arm and 1.5 months in the dacarbazine arm. And the FDA had just approved pazopanib based on a progression-free survival endpoint. It's the first drug that they did that with. And the magnitude is similar. So they thought they should approve trabectedin. So it was approved in this study for leiomyosarcoma and liposarcoma. In fact, it's used in many of the sarcomas. Eribulin had a similar development strategy. Again, randomized versus dacarbazine, leiomyosarcoma and liposarcoma only. Primary endpoint was survival, secondary endpoint PFS. Interestingly, this study was positive for survival, but when the FDA broke down the groups, or asked the company to break down the groups, it was clear that all of the benefit was in the 1/3 of patients who had the liposarcomas, not in the patients who had leiomyosarcoma. So this is fascinating because twice as many patients had lio as lipo. But still, because the liposarcoma patients did so much better with eribulin versus dacarbazine, they actually ended up showing an overall survival benefit for the entire group. But again, what contributes to that overall survival? I'm not sure. I'm not sure it's all trabectedin. But progression-free survival, 3 months versus 1.7, it was significant. And the drug is approved for use in patients with liposarcomas. So we have some new drugs that are approved. Just have to figure out how best to use it. So I'm gonna quickly, because I went over time, unfortunately, go over the use of chemotherapy in a curative setting, because that's what it's really all about, right? I mean, if you do these initial studies in patients who have pretty far advanced disease, and the major hope, although you're trying to cure most of the patients, the fact is that most of the patients will not be cured. They may have their lives extended. But if you have drugs which kill cancer cells, and you use that at a time when there are fewer cancer cells present, then you can cure patients. And so, you know, doctors are strange beasts, and they always argue about how to do things. And I was asked to give a talk on, could we reach a consensus on adjuvant and neoadjuvant chemotherapy? And I said, the answer is no, because you can never reach a consensus. But what's clear is, you know, if the wheels on a Mercedes are round and the wheels on a Lexus are round, you really don't need to do that same study on every single make of automobile. A wheel is round. We have done the experiment of curing other cancers by adding active treatment early on in this area. I mean, there was a time 35 years ago when there was a big argument of should we treat patients with osteosarcoma with chemotherapy, because we weren't sure that it was helping. I mean, luckily some of us didn't listen, and luckily Marcel was treated only 30 years ago, so by that time most people have done pretty much the same. But it's clear that patients with big sarcomas die from metastatic disease. And no matter what you do with surgery and radiation for the primary tumor, you're not treating the metastatic disease that's there. It's true that the chemotherapy that we currently have is limited, but it's better than it used to be. And in fact, aggressive chemotherapy given to patients with a very high risk of metastatic disease can probably increase their cure rate by about 20%, which is not nothing. It's not enough, but it's not nothing. So rather than arguing, should we do chemotherapy for patients with high risk of metastatic disease, we need to be figuring out how to make it better. And that's what the design of the future studies should be. But the concept of neoadjuvant chemotherapy is, and I should define for you the terms. Neoadjuvant chemotherapy means giving chemotherapy before surgery of the primary tumor. And the great advantage of neoadjuvant chemotherapy is you can tell whether you've had any benefit. Because clearly, you're not going to benefit everybody. If you know who you benefit, you know who to give the toxicity to and push on. If you do the surgery first, unless you have a treatment that's uniformly successful, it's probably not a good idea to use it. That's what's called adjuvant chemotherapy. So we're big fans of neoadjuvant therapy. The key thing is figuring out who needs it. That is, who's likely to die of metastatic disease, that get them treated up front. So I thank you for your attention. I apologize that I went a little bit over, but I'll still take some questions if they'll let me.
Thank you, Dr. Benjamin. We're going to go into a 5-minute break, and Dr. Benjamin will be up here to address your questions, and then you're participating on our lunch panel, so you'll be available for questions as well during that. So thank you so much. Quick bio break, everybody.
Okay, Alyssa, will you have
Hello, everybody. We do have a box where you could enter your questions for the physicians panel. I'll bring it in and we'll